Very good evening, everyone. It's great to meet you all once again. I take a great pleasure in welcoming you all to the day 3 of Holistic Approach to ABCs of Intervention Cardiology. We had a great academic feast for the last 2 days with 5 international faculty talks, 5 national faculty talks, and 2 live cases, and more than 20 case discussions from all the national faculty. And almost 1,200 attendees attended this meeting last 2 days. And today's focus shall be on calcium. And today we have 2 sessions. One is Learn from the Masters and Keynote Lecture by 2 international faculties. One is Dr. Michael Krukov from America, US. And next is Giulio from Italy. A live case from Metro Hospitals, Calicut in India. And we have 10 expert strategies by various experts in the management of challenges in calcium. And we have an exciting debate and a challenging case discussion session over 180 minutes of learning today. Without much ado, I hereby start the day 3 of the conference with expert strategies session. Now, we shall be splitting into 2 groups, that is box 1 and box 2. I request each one of you to check the About tab in your screen, and you can move to the respective box according to your schedule. And then now, to take over these sessions in box 1 and box 2, we have moderators here, Dr. KP Suresh Kumar, who is a senior intervention cardiology from Kaveri Hospital, Chennai. He is practicing actively clinical and intervention cardiology for the last 25 years. He is a pioneer in radial access interventions and balloon mitral valvotomy. And we have Dr. Rajesh from Amrita Hospital, who is having more than 20 years of experience in complex coronary intervention, good experience in physiology and TAVI. I ask both of you to take over the box 1 and carry on with your moderation there. And for box 2, we have very good friends of mine, Dr. Keshavamurthy B. and Dr. K.U. Natarajan. Keshavamurthy is a senior intervention cardiologist, my colleague at Tanjavur. He is one of the high volume operators, has done more than 5,000 angioplasties, and an excellent thinker. And then he has a lot of innovative procedures designed by himself. We all adore him for this. And we have Dr. K.U. Natarajan, the past HOD of Amrita Hospital, Cochin, for the Department of Cardiology, a very great person, very nice man who has more than 20 to 25 years of experience in complex coronary intervention and good experience in rota and vessel closure, and a very good electrophysiologist too. I hereby request the moderators to take over the session and go ahead with today's proceeding.
Good evening, everyone. Thank you, Dr. Selvamani, for the kind introduction. And today in our session on coronary calcium, we have got 5 presenters. It's a packed session. And me and my co-moderator, Dr. Rajesh, will moderate the session for the next 1 hour. We have got an eminent panelist for senior cardiologists. One, Dr. Ravi Kaldra, is the HOD of Bharati Vidyapeeth Medical College Hospital, Pune. Dr. Padmanabha Kamath, he is HOD of Cardiology, Kasturba Medical College, Mangalore. Dr. Devadatta Bhattacharya, he is the Chief of Cath Lab, Rabindranath Tagore International Institute of Cardiac Sciences, Kolkata. And Dr. Jawahar Farooq, the Senior Consultant Interventional Cardiologist from Ramanathapuram. Without wasting much time, we will start our presentation. We will keep the discussion after all the presentation at the end of 5th presentation. Over to you, Dr. Rajesh.
Yeah, thank you,
Rajesh.
thank you, Dr. Suresh. And now we will go on to the first presentation. I think it's about superficial calcium by Dr. Ajay Swami. Over to you, Dr. Ajay. We got exactly 10 minutes to finish the lecture.
All right, sir. Are my slides visible?
Yeah.
Yes, very much.
So before I begin, my salutations to my teachers, some of whom I see in the audience and some of whom are not. I wonder if everybody could mute their mics so that I can speak without getting distracted. I have a lot of information in the next 5 to 10 minutes. Calcium, superficial and deep, basically definition is where we see it, whether we see it at the intimal luminal interface or closer to lumen. When it's closer to the lumen than to the adventitia, it's known as superficial, and it's closer to the adventitia than to the lumen, it is known as deep. And unfortunately, patients, the disease has not read the book, so very often we have both in given patients. This definition was given in 1995, and we followed it, and it seems to work quite all right, especially with OCT. So I'm going to quickly do a case-based presentation. This is a 76-year-old male with hypertension and dyslipidemia, class 3 angina, frail, unwilling for CABG, and you can see that he's got diffuse disease in the LAD. And after a small dilatation, when we did the OCT, this is what we found. So we have deep calcium, almost circumferential in some parts, superficial calcium in some parts, and a combination of eccentric and concentric calcification right across the LAD. Now, how do we deal with this? That's what we're going to see. Our second case is an 82-year-old with crescendo angina for 2 months, had an angiogram a year ago. It was advised CABG, refused, brought to the emergency with ongoing chest pain, with a BP of 80, global ST depression and ST elevation, convinced to undergo an angiogram, and this is what his angiogram was like. So this was a patient who was not very hemodynamically stable. The IVP was placed, and since the pressure was damping, the guide was dehooked. In summary, this is an elderly male with shock, with heavily calcified left main, with TIMI2 flow, non-dominant circumflex, and a normal dominant RCA. The third case is an 86-year-old male with crescendo angina for 4 months, global ST depression on ECG, with LV dysfunction, ongoing pain, and this is what the angiogram shows us. One is an AP and
Ajay sir, your volume is very low. Ajay Sami sir, your volume is low. I think you should come near to the mic or do something.
Okay, sir. Let me see what I can do.
Am I audible now?
Yeah, very good, sir. Now excellent.
Okay. All right. So this is a bifurcation left main, which you can see that there's a large filling defect at the bifurcation. Now, how do we deal with all these problems? Elderly male with ACS, ongoing angina, LV dysfunction, I'm sorry for the interruption, with an apparent filling defect within the left main extending into the L6, unstable hemodynamics and poor LV function. The treatment options for calcium are basically plaque modification, rotablation and orbital atherectomy, and balloon dilatation-based techniques, that is an NC balloon, a scoring balloon, a cutting balloon, and the new kid on the block, the intravascular lithotripsy. Now, the cutting balloon essentially has atherotomes with a gap at 5 millimeters, and this is a sharp blade which comes out in different 2 to 3 blades usually, depending on the size. And this is the kind of cut that we get after using a cutting balloon. And in a scoring balloon, this is a more blunt nitinol wire wrapped around the balloon. And this is the kind of modification that we get after this. The other one is the OPN NC balloon. Essentially, this takes away from the dog boning that we get. NC balloons, we think, don't dog bone, but at higher pressures, all the NC balloons dog bone. And this special manufacturing quality of the OPN gives a predictable amount of pressure without uncontrolled radial and longitudinal growth, thus eliminates the dog boning. This is what it looks like. You can see the balloon expanding, and this is the kind of expansion one can get with the OPN. Now, there are certain tricks for the OPN. We don't use polymer wires, use support wires, 0.5 less than the reference diameter pre-dilating, and 1:1 when we post-dilate, and increase the pressure gradually after 20 atmospheres. What happened to our cases? This was our first case that we saw, who was unwilling for CABG. This is the imaging that we saw. Now, we did an IVL for him. And this is what happened after the IVL. These are the kind of cuts that one sees superficially as well as deep in the OCT. And this is the comparison before and after the IVL, and this is after the stenting. And this is what it looks like at the end when we do the last. This is a combination of superficial and deep, underwent IVL with a 312 balloon and an NC, 2 long desk placed with an excellent result. This is our 82-year-old with the TIMI2 flow in the distal LAD and the distal circumflex. And what we did for him was a rotablation. It was a little difficult to get the wire in, but once the wire went in, thereafter it was quite easy. This is the microcatheter, the rota wire, and we always take the rotablation in segments. So this is first segment, second segment, third segment, and the polishing run, which goes all the way through with no deceleration at all. We continue to burr until you have a less than 5,000 deceleration. And this is after the check, after the rotablation for no flow and for no perforation. The wire in which we put the wire into the ramus again, pre-dilate the left main with an angioscalp. This is our plaque modification that we used in this particular patient. And then we cut the ostium with a cutting balloon. So the important thing is to use multiple combinations and a long NC balloon thereafter. The stent, the pot, the shaft, as well as the ostium separately with bigger balloons. And that's the final result that we get. We just opened the OM, the ramus as well. And this is the angiogram after the kissing balloon. And that's our final result, which is perfectly acceptable and looks good. We did a repot thereafter, a final pot. And that's what we get in the final angiogram. This is the before and the after images for comparison. I'm going a little quickly so that we are able to, this is our 86-year-old with the left main bifurcation. Since we couldn't do a rota because of significant thrombus, we opted to do plaque modification aggressively with multiple balloons. And that's what this patient underwent. This is the first wire with the IABP. This is second wire into the circumflex. This is the opium balloon, which we used to open the ostial circumflex, the cutting balloon of the ostial LED, because that was the first stent that we wanted to place. The non-compliant balloon for the ostial LED, which we use as a balloon palpation technique to make sure that it is going to expand properly. The opium for the ostial circumflex. This is the angiogram post balloon. Stented LM LED crossover, then rewired the circumflex through the stent, opened the stent strut, positioned the circumflex stent, and then did a pot and a final kiss. And that's our final angiogram. In summary, calcified lesions make it difficult to deliver hardware. Underexpansion is a problem that leads to restenosis and stent thrombosis. There are multiple options. Imaging has changed the way that we approach calcium in the coronary. The aim is to get the best result with a combination of the available techniques without compromising safety. What I have tried to show is that in every single patient, we used a combination of different techniques depending on the distribution of the calcium and the kind of clinical situation that the patient comes to us with. Multiple tools need to be used. There are objective criteria that when it is less than 500 micron depth of calcium, balloon-based plaque modification techniques may be adequate, but thicker calcium needs removal or atherectomy devices. Deep calcium and thick calcium, IVL is the best. And as I said, rules are for the guidance of the wise and blind obedience of olives. Thank you for your attention. And I think I've just finished in time.
Thank you, Dr. Ajay Swami. Now we will go to the second presentation by Dr. Jaspal Arjina. He's the Director of Cardiology at Arnija Heart and Multi-Specialty Hospital, Nagpur. Over. Dr. Jaspal?
Yeah.
But if there's a delay, we'll go to the third presenter, then we'll come back to you. Rajesh.
Suresh sir, if he is not able to join, probably we'll go to the next speaker and ask him to join a bit later. Yeah.
Yeah. Dr. Rajesh. Yeah.
Dr. Ayankar, are you there?
Rajesh has muted your.
I'm here. I'm here.
Yeah, please share your screen and start your presentation. You're going to talk about deep calcium.
Okay. So I cannot share till the previous participant stops sharing. So,
Dr. Jaspal, can you stop sharing now? Yeah.
Just a second.
So thank you, everybody. Good evening to all my teachers, and thank you to Dr. Selvamani and Dr. Bhattacharya for giving this opportunity to present in front of this august audience. So today we will be talking about management of deep calcium. And so, as you know, in today's date, major determinants of complex PCI generally tortuosity, thrombus, diffuse disease, and last but not the least, calcium. So we will be talking about calciums, which are now commonly put together by the term known as lesions with high calcium content, so LHCC. So as delineated before also, so we have certain tools for calcium management, and that of course includes a plethora of tools, as you can see. But we would be largely talking about deep calcium, and that is amenable to a certain kind of balloon that is known as the lithotripsy balloon, which is currently available in India. And apart from that, before going to my two cases, I would like to talk about the imaging modalities available and their general shortcomings. So we'll be talking about overall that IVUS and OCT both can be used in these kind of cases. But one of the shortcomings of IVUS over OCT is probably that of calcium thickness, and that is something that is very well delineated by OCT, and that is something that we wanted to show you. And yes, this is the calcium score that we were talking about, which was depicted by Fujino A and Gary Mintz. And as you can see, calcium angles of more than 180 degrees and a thickness more than 0.5 millimeters and lengths of more than 5. When you have a score of more than 4, your chances of under expansion are very high. So these are the kind of patients where you need plaque modification therapies. So coming quickly to our first case, we will go to, that is the 74-year-old male, diabetic hypertensive, had an anemia due to a GI problem, but gradually sorted out, had a PTCA to the LAD, now presents again with unstable angina, severe calcific double vessel disease, ejection fractions of 50, and we decided to go ahead with an OCT guided IVL with the PTCA stenting both to the LAD and RCA. For the short of time right now, we will skip the LAD and go to the RCA, because the RCA was the more interesting lesion as far as deep calcium management is concerned. This is, as you can see, even from beforehand, you can see the tram track calcification that is present in this RCA with a very tight disease at that prox RCA, as you can see, and that is exactly delineated there. And that is our initial run from the OCT, and that is something which is interesting to note is the high amount of calcific content out here. I mean, hypoattenuation with very well-defined margins. And I would like to quickly forward you to the tightest part of the disease out here. And yes, that is the tightest part, and that is something that you want to really do something about. So interesting part is, let me stop this here and we'll go back here. So that is the tightest part of the RCA segment, as you can see. As you would see that here, it does not appear like calcium, that is with well delineated borders, probably because of the tightest part of the lesion out here. And so initially we went ahead with the pre-dilatation with the 2.5 into 15. We went up to 22 atmospheres, but you can see that there is a significant waste out here which did not go, which is why we decided to go ahead with the IVL out here. So that is the, in order to show exactly how this tightest part exactly looks on a three-dimensional tomographic image out here, you would see here that it's a, we wanted to look at calcium basically if it was available for seeing from any other angle or view from the rotational image out here. But as it appears that for some reason the beam is hypoattenuated out here and the calcium is not very well depicted. So which is why we went ahead and did took our IVL, that is a 3 into 12 IVL, and we went in for 6 pulses of 10 pulses each. And then as you can see, gradually the balloon from 4 atmospheres, we go up to 6 atmospheres, and gradually the lesion gives way. And so we went ahead, and now you can see that the waste has gone, and now there's a good lumen available for us to stent. And this is post calcium, and this is, I would like you to keep a watch at our 2 to 3 o'clock and the 6 o'clock images, and you will gradually see this is a short part of the OCT. And yeah, there you can see the nice cracks out there, both in superficial as well as the deep calcium. So yes, those are the cracks which are a little better appreciated out here on the still images from the OCT, and that is the co-registration with the angiogram out here. So we went ahead and stented with a 3.5 into 28 des, which nicely expanded at 12 atmospheres. We post-dilated with a 3.5 into 12 up to 22 atmospheres, and the end result is good. And that is the final fly through, as you can see, from the proximal to the distal on the OCT, and we have a well opposed stent and nice lumen achieved at the end of the procedure, and that is the final result, which is very well acceptable. So next one is another modality of imaging that I would like to show you. This is the IVS Assisted IVL, and this is typically one of the type of cases we generally get a lot of concentric calcium, and that is a CKD patient, maintenance hemodialysis, presents to the emergency department with unstable angina, a tropi of 12, labs are fairly okay with a creat, of course, which is 8.4. He's anuric at the time of this procedure and requires dialysis. So as you would appreciate, again, there is a tram track appearance out here. So it's a large dominant circ, and there's almost a 70% lesion out there. The RC is non-dominant and free from significant disease, and this is the IVUS run through of that image. So as we do understand that IVUS helps pick up the arch of calcium, but given to the acoustic shadowing, sometimes the thickness of the abluminal calcium is something that is not always appreciated on an IVUS very well. But nevertheless, as gradually now you would see, this is the tightest portion of the disease out here. As you can see, it's quite compromised lumen out here with a lot of calcium out here, which definitely needs some modality of plaque modification. So again, we went ahead with a 2.5 into 15 NC. It doesn't open, a lot of waste out there, and I'm sure you would appreciate that waste here on this angiogram also. So second pre-dilatation, because the IVL balloon is a little bulky device, we intended to have some space to pass the balloon through, which is why we went ahead with the second pre-dilatation, and we made some room for the balloon. And as you can see, after then gradually we went up to 6 atmospheres, so you can see that the balloon expands well. And this is the result after IVL, and which is quite acceptable, and it's nicely opened up. So for comparison's sake, the pre-IVL and the post-IVL. Yes, and so this is just to show you the luminal gain, although the cracks may not be as well appreciated as it was on OCT, but definitely you can see that there is some cracks which is seen in the calcium out here, and we have good luminal gain. And so after post IVL, there is no waste on the balloon, as you can see, and that is the image on the angiogram out there. We went ahead and stented with a 3 into 26 des at 11 atmospheres, which was post dilated with a 3.5 into 15 NC, and that is the final IVUS image, which shows you MLAs, very well documented MLAs in the LCX with no evidence of edge dissection and no stent malapposition. And that is the final result at the end of the procedure, which I think is a really good result out here. And yes, so I'll just put in a take home. So it's all about assessing the lesion well. So these kind of lesions, it's very important to have your share of imaging out here, preferably when you're dealing with deep calcium. It is OCT that is needed in your lab. And look at those three parts: the calcium arch, the calcium length, and the calcium thickness, and then decide on the type of plaque modification that you want to use, whether it's rotational atherectomy, whether it's IVL, whether it is cutting balloons, whether it is the OPNNC. And of course, that makes the strategy much more simpler. Thank you so much.
Thank you, Dr. Iyengar. Now the next presentation is by Dr. Sridhar Kasturi. He's a very senior consultant interventional cardiologist at Sunshine Hospital, Hyderabad, with almost 25 years experience. The topic is on eccentric calcium. Over to you, Dr. Sridhar Kasturi.
No, yeah.
Yeah, am I visible?
Yeah, very much. Yeah. Please
Good
go
evening.
ahead.
Good evening to all of you. I'll be showing two cases, mainly emphasizing on eccentric calcium. This is a 64-year-old female patient, non-diabetic and hypertensive, presented with ACS unstable angina, severely calcific triple well disease. Patient is also having a bilateral carotid artery disease, actually related to one of the cardiologists, and patient was not willing for surgery. He himself accompanied, so for PCF triple well disease. No ECG changes, but classical angina, 2D echo normal LV function, COVID negative, CT chest, no evidence of COVID. And anemia was there. It was corrected prior to procedure, GFR 99. So you see the angiogram, there is a severely calcified LAD disease, almost long segment involving the proximal and mid. And LCX from the origin, it's severely diseased and multiple tandem lesions, which are severe, involving the OM branch, which is a very large one. And if you see the right coronary, CTO, right coronary also calcified, there are plenty of collaterals, septal collaterals. But main problem, LAD is severely diseased. So our intention is to go ahead with the PCA because the carotids. So do the coronaries first and subsequently go with the bilateral carotid stenting. So this is the case where initially we wanted to minimize the contrast, at the same time reduce the procedure time to avoid the ischemic cascade. So that's the reason initially we thought of we'll go ahead with I always see the balloon behavior, how it is behaving. And LCX, I didn't find any calcium much. And our intention is to preserve the imaging for post-PC optimization to shorten the procedure time. So they dilated, and this is run through wire and Versatile in LCX, BMW and LAD, OM pre-dilated. And that OM was stented initially with 2.25 into 22 mm. Initially, we thought of we'll go with, in the last 2 years, I did almost 50 DK crush of left main stenting. So I did mini crush very long back because of the MACE rate. So this case, because of the procedure and other things, I opted for mini crush. And this is the first stent implantation, post-dilated, 2.5 into 12. Then this is a stent, 3 into 15, resolute onyx into the LCX, and the proximal LCX stenting was done. So LCX stent, one crushed with a 3 into 12 mm NC balloon. And LAD lesion is very tough lesion. There was a dog bone lesion, effect, and we were unable to dilate it with a regular NC. So very severely calcified lesion and unyielding lesion. And then we used we kept the rota for just reserve sake. Only thing is right coronary CTO, we gave temporary pacemaker backup. Suppose if the LAD is slow flow, no flow, is the LCX already severely diseased, patient may not tolerate. So initially we thought of do the open NC, if still not yielding, just go with the rota. Then we took 2.5 mm open NC, dilated, you see that got ruptured. See the open NC balloon, that's ruptured. And then subsequently we did the 2.5, another open NC balloon. So then you see how I'll show the ruptured open NC. You see the first view, the ruptured open NC balloon. And then the second open NC tried 2.5 mm, and that also got ruptured. This is most often happens if there is a calcium nodule, spicule is there, it can perforate. So 2 open NCs perforated, then subsequently, so we have to dilate. Then I thought we'll do 3 mm open NC. If it is not opening, then we'll go ahead with the rota. That was our strategy. And with the guideline support, then 3 mm open NC, 45 atmosphere, relatively dilated very well. Then subsequently, we implanted 3 into 38 mm resolute onyx. This is mini crush technique. Then part was done 4.5 into 18. Then so far it's so good. You can see the then dilatations. This is a dot dilatation of the LAD optimization, expanded very nicely. Unfortunately, almost 8 to 10 times we were crossing the LCX with repeated wides, but none of the balloon is crossing. Then we took Nick Nano. Nick Nano crossed, dilated. But after that, again, we tried 1.25, 1.5 new Tazuna balloons, almost 2 to 3 sets. But unfortunately, none of the balloon is crossing. Wire is going, balloon is not crossing. Then we used the Crusade. We took the Crusade, and with Crusade, because all the time the wire was going through the proximal strut, maybe slightly raised struts. Then we wanted to change the course of the wire, then put the Crusade, and with the Crusade, then we crossed the distal strut, and subsequently part was done. Almost part was done repeatedly, at least to open the side branch ostium. Despite of repeated parts, it was not opening well. And this is the image. Then we thought of seeing why it's not happening, why it's not crossing. You see there is a significant eccentric calcium, but if you see proximally, this is the guide wire. I was wondering whether that wire went through the abluminal portion of the left main component, but it's in the true lumen, but there is slight malposition at the proximal portion, that the distal portion of the LMCA. It was all the time entering to the proximal strut. So it's like almost cramped portion of the stent struts is going. So that's the reason wire was not going. You see the very thick calcium, eccentric. Other side is multiple fractures you can show. I'll show the subsequent analysis also. And the stent is very well opposed in left main. So beautifully opposed. Only thing is it's not properly, the alignment of the wire is not proper. You can see that everywhere the left main size 14 square mm, 4.2 diameter, Australia 10 square mm, 3.2. So expansion is very good. Only problem we faced to enter into the LCX. That was very difficult. So here you can see the fracture with open NC, and you can also see multiple fracture. Here also you can see, and that open NC yielded the lesion very well, prepared very well. And if you see the fracture here and LCX, you can see the nicely open, but here there is slightly raised proximal, the distal portion of the LMCA and proximal strut. So the wire going through this cramped portion, the crushed portion of the LCX stunt. So that's the reason we were facing, though wire was going, the balloon is not going, not yielding. So because of that, we changed the strut position. This is a crusade. Then we use the crusade. See, not going. This we thought of any wire entanglement. Then this is the crusade, and you can see next. Then nicely you see that one wire through the crusade, another wire cross. Then subsequently, then we did the kissing balloon 3 and 3.5 mm. Then nicely opened. Then part. This is the final angiogram. So nicely opened, and that is the beauty of the crusade or Sasuke, any 12 lumen catheter. When wire alignment bias are there, you change the strut position using the, here we put into the LCX, and we have chosen another strut using the dual lumen catheter. This is another case, 77-year-old female patient, hypertensive and old CVA, left hemiparesis in 2013. She fell down, and subsequently she sustained left intratrochanteric fracture, and because the fracture stopped antiplatelet therapy and developed inferior wall MI, she came to hospital with post-infarct angina. So this is a right corner lesion, 77-year-old female, and there is a tight lesion. So this is a balloon uncrossable lesion. We were unable to cross a lesion with a balloon beyond this lesion. So patient was having a post-infarct angina. There is a tight calcium. So when then balloon uncrossable lesion, for us no option, we exchange the wire, then floppy, rota floppy, and this is rota 1.5 bar, 1,50,000. So then OCT performed. See the OCT, you can see distally, this is a fibrous block, this is areas of calcium, and proximal if you come, there is severe eccentric calcium, and there was a calcium nodule. So this is a lipid block. And proximal if you come, then you can see very clearly some calcification. You see this is a calcium, but thickness is less. Here you see the eccentric calcium. This is almost calcific nodule. And here also calcium nodule is there. Fractures you can see very clearly. Dissections you can see very clearly. And you see a big chunk of calcium eccentric. This side normal, this side calcium. The major calcium is this side. So this is the analysis. You can see the calcium very, very eccentric. Though sometimes if the calcium eccentric, if the lumen area is adequate, rota may slip and it may not cause the burring of that eccentric calcium. But if it's very, very tight calcium, then it can ablate the even eccentric nodule also. In such cases, I found even open NC also very useful. It can expand the stent, it can create the fractures, is as effective as rota. Nowadays we are doing one open NC registry also, it is extremely useful and alternative to ROTA in some cases. And this is the, subsequently, we use 3 into 40 mm RC Rostan. And this is the, you can see the nicely expanded stand. And you can see it's a expand. Despite ROTA, you can see asymmetrical expansion because of the eccentric calcification. The one of the disadvantage of the eccentric calcium, sometimes you may not remove the total, the calcific nodule or whatever the eccentric amount of the calcium. So in that case, what happens, it may lead to elliptical index of that 0.7, at least it should be above, it should be achieved. But the elliptical index, you may not get optimally. In such cases, you have to take the open NC or some other high pressure NC balloon dilatations. Otherwise, expansion will not be adequate. That is, which is the determinant of, here if you see, nicely expand 6.65, 6.6, and 6.7, 4.7. You see, this is the calcium, this is the normal, and this is the eccentric portion. This is also eccentric calcium. And you can see asymmetrical expansion, still residual lesion is there. In such cases, better to take the high pressure inflation. Otherwise, that may. But here we achieved adequate area as per the CLIO CI study or even a recent European Society of Cardiology guideline. Anywhere the mean luminal area, mean stent area more than 4.5, proximal or distal inside the stent, that is adequate. So 4.5, this is, we got 4.7, but this was done about 3 years ago. But even if I get this kind of lesion, I take always the open NC and go with high pressure. See that you are achieving at least more than 80% compared to mean reference area. This is the final result. So these are 2 cases where eccentric calcium is associated with asymmetrical expansion, associated with increased incidence of perforation. If you are putting more pressure, sometimes the portion between the hard portion and soft portion, it may give away, and that may lead to perforation and extravasation and dissection, underexpansion, malabsorption, very common. Needs adequate plaque modification prior to desimplantation. Image-guided post-PC optimization is very, very useful to provide a better short-term and long-term results. Thank you one and all for paying attention. That's
Dr. Suresh, sir, Jaspal's presentation is ready, it seems. You can invite him when you want.
Yeah, then we'll go for Dr. Jaspal. Dr. Jaspal.
Can you present now?
You can
Hello,
start
Dr.
your presentation.
I think if Jaspal is not there, can you invite Dr. Pratap Kumar?
Yeah, I think we can go to the last presenter. Dr. Pratap, please go ahead, Dr. Pratap.
Dr. Pratap is a very highly acclaimed interventionist from Kerala. He's going to talk about precision PCA in fatty calcific lesions under OCT guidance.
Some problem is happening. Just 1 minute.
Getting the wire into the LAD, that bend was really tight, nasty bend, and the wire would always go into the other side.
Can I go ahead?
Please go ahead.
Okay. It's a fatty calcium is a very tough. I don't know what topic he has given to me.
Yeah, please, Dr.
Oh, okay. Can you hear me?
Yes, yes, very well.
Okay.
Yeah, very much. Yeah.
Calcified lesion ostium is actually the OCT in actually signal poor or a hip with a sharply delineated leading with the lateral borders. DD is actually lipid or a necrotic core. You have a lipotic core is actually poorly defined borders, and calcium is actually sharply delineated borders. You have a limited penetration and higher spatial, actually limited these things. OCT challenges are actually non-homogeneous plaque, that is fibrolipidic calcific, or if the calcific deposit is very deep or calcium is underneath the lipidic core. That is actually the problem here. Angiogram it will identify the calcium, calcify the calcium eccentricity. Calcium will the calcium angle thickness volume when your angle and length is seen by PCI guidance is important because lithotripsy cutting balloon, it confirms the calcium cracks modification to identify the complication or suboptimal result. Phenotypes when to do atheractomy if you are actually having heavily calcified lesion area and thickness is not done properly, you will have a stent under expansion. You know this formula. Showing 3 cases. It's a 58-year-old female male patient with a diabetic hypertensive.
Yeah.
There is a BC lesion in the
Pratap, sir. Pratap, your internet is very slow. So I think you can switch off your video and just go with the presentation so that it will become a little bit faster.
okay.
Your internet at your place is very slow, so it is coming slowly. Just switch off your video. Yeah, fine. Now you go ahead, sir.
Okay. You can see there is a lesion in the lesion nearly extending to the plex. You can see this actually leads. One is a dissection plaque, calcium, thrombus, significant plaque. We thought it's a lesion, and I was actually identified.
Problem with Dr. Pratap's present internet.
Just go into the details. You can see that is a so we did the LED. I was to really, you cannot see. You can, Illuminate cannot see.
No, there's a lot of lag in your
presentation. Yeah, that's fine.
Oh my God.
No, but it's a little bit slow, but I think you try, you go ahead.
Okay, because the time is also important, you know.
Yeah.
I used the 1.75 rota to circumflex, and with the 4 into 12 millimeter balloon, I thought there is a lot of calcium by IVS. Post rota, there is no significant difference seen in the rota. Actually, pre and post, I could not see any difference created by the rotulation. You have a calcium which is extending into this region. So we did an IVS OCT and C. OCT was actually showing a totally different one. You have a fibrocalcific plaque with a fatty nature near the early OM region. So distal circumflex was thin superficial calcium, and a 90-degree calcium with an overlying thrombus was there in that part. It's actually a fatty plaque, fatty calcium was there. So we did just go ahead with a 4 into 15 millimeter DES at the ostium, and we did a mini crush technique, stent inflator, wire recross, kissing inflation, final pot. We did a post-ending again. We saw the post-ending LED ostium is 8.8. We did a final OCT to both regions. You can see that stent well expanded. At the same time, there is a small malapposition in that part. We have a circumflex, actually 3D bifurcation showing an excellent opening there. Even this lumen is well opened up. It is a run through. There is some malapposition in the proximal part. Again, it is a stent run through. We can see a malapposition. You can see actually some malapposition which is actually seen as 0.7 millimeters. So we went ahead with a 5 millimeter post dilatation and finally produce a result. So we actually, what I learned in this case, actually, if I did an OCT earlier, I would not have gone with a rotablation and just finished the procedure without that. So it is actually a fatty calcium was there. Could you see anything or it is difficult to see?
We can see now clearly, no problem.
Okay. This is the second case actually as PCI to circumflex, which is actually done an angioplasty in 2003. A totally different standard segment, which we don't know, but it's a standard segment, totally occluded vessel, multiple balloon dilatation done. We finally crossed with the Miracle 6, crossed the lesion. We don't know whether in severe calcium with the narrowing seen in the, especially in the ostial circumflex with a lot of dissection. We could not identify what, but we went with an OCT there. OCT could identify a lot of fatty streak as well as underlying calcium was there. A heavy calcium with intimal tear also, tear created by the balloon dilatation. Length of the pre-standard segment of the circumflex was 14 millimeters, but calcium present even underneath the stent. And the stent, there was no standard segment for the first 14 millimeters, then there was a standard segment. Dissection in the proximal part of the circumflex with a severe calcium. So what we did is actually no balloon could open everything. What we did is actually there is a 1.2 millimeter depth of calcium was there, significant calcium. But image helped me to understand the problem. Significant concentric calcium, but depth and area is very not clear. ISR and stent with the calcium make me more confused. But OCT make me a clear understanding of the calcium thickness, area, ISR, and the standard segment. What we did is actually a rotablation with 1.5. Finally, we landed like the result like this and produced a good result. We did an OCT, which confirmed that the stent is well expanded and we got a reasonably good area in all these parts. This last case, this patient actually had an angioplasty done for the NSTEMI for the LAD segment, and the RCA was totally deceased. This was actually, I saw the patient with the RCA stenting because circumflexus RCA is totally occluded. We tried with the field FC, failed to cross, but finally we crossed with the Gaia second wire. We were not sure that the wire is in the distally in the true lumen, but we confirmed with a retrograde injection, confirmed that wire in the PLV. Once it is confirmed, we tried with the 1.25 into 10 balloon, which is not crossed. Corsair also could not cross the distal lesion. We actually did what? We did a balloon into the PDA. We kept filter FC into the RPDA with a 2 into 8 millimeter, that is actually an anchor balloon, with 1.25 balloon again could not cross. We did a fine cross in the RPLB. We did a rotablation, rota wire into the RPLB. So retrograde injection confirmed that whether our rota wire was in the right place. Once we confirmed, we did a rota, but the rota should extend up to the PLB. We use a 1.5 rota bar up to the proximal to the mid part. Then we went distally up to the PLB part. Totally rotablation from the proximal to the distal PLB. After the rotablation, this was a result. What we did is actually we used a 3 into 12 NC proximally, then 1.25 emerge and 2 into 8 millimeter distally we inflate. After that, we did an OCT. This was the OCT run. OCT was showing a significant fatty calcium throughout. You can see a fatty area with the calcium underneath. It totally, you can see the total lumen itself is very small. You can see the proximal RCA was the score was 4, arc is more than 180, length is more than 5 millimeters, thickness is more than 0.5. So when we go into the calcium is so thick and we could not see, you can see a fatty plaque in the superficial part with some dissection is created by our balloon dilatation. So in the mid RCA, again, the calcium score was 4. When you go to the distal RCA, again, the calcium score was 4 with the thickness of 0.86, length of 7 millimeters, and calcium arc is 360 degree. So what we did is actually after balloon dilatation, with the help of the guideliner, we used a 3.5 into 38, 3 into 28, and 2.75 into 28 science expedition stent was used. and a 3 into 12 millimeter balloon and 3 into 8 distally in the PLV and a 4 millimeter. This is the final result with the OCT measurement. You got a reasonably good area. We got an area extending from 7.28 to 14.75 from the proximal distal to the proximal, which was only 1.6 millimeter up to 2.53 in the initial level, which was actually extended up to 7.28 in the distally, and we got a 14.7875 in the proximal RCA. So in principle, IVS actually identified calcium thickness and the calcium arch along with the longitudinal length of calcium, which was not identified by OCT identified these things, which was not identified by the IVS. So IVS OCT is a much better tool in identifying the calcium, especially mild to moderate, along with the fat underneath. OCT, in contrast to the IVS, can often assess calcium. Total calcium arc more than 180 and increased calcium thickness also with a great risk of underexpansion. Evidence of calcium fractures following the lesion preparation, improved expansion. In case of large 180-degree calcium pool, absence of fracture involved following initial lesion preparation, definitely this to be considered. Thank you very much.
Thank you very much. Dr. Jaspal, if you are ready, you can show your presentation. Dr. Jaspal Arnija, if you are ready, you can show your presentation. Otherwise, we will, if there's a delay, I think we will conclude. And I will over to the panelists and Dr. Rajesh to conclude.
Yeah, I think we had excellent case
Panelists for the comments. This is an excellent demonstration of it's an excellent case presentation of coronary artery calcium. All of them have shown very good benefits of OCT over IVS and the utility of OPN balloons, IVL, and cutting balloon apart from rota in coronary calcific lesions. Excellent cases, tough cases. Thank you very much. And over to Dr.
Yeah, all cases were very good. I have just one or two doubts. Just want to ask Dr. Sridhar, that patient which you showed, LAD circumflex bifurcation, the first OPN balloon ruptured. Why did you persist with the second OPN balloon? Preferred a rotablator when you know that there's a lot of calcium there, and then
previously we did 3-4 cases actually with higher openness. It's nicely opening. So because purposefully I wanted to avoid the rota in that case because the RCS CTO was there. L6 is diffuse disease. Already we have put one stent. That is a proximally projected studs are there, and that calcium is projecting from the LAD ostium. If I do, I may disturb the proximally protruded stent studs. So that time, if I have to use the guideline and to slightly park into the LAD and do it, the ostial calcium was there. So that's the reason I wanted to keep it as a second option. I was very confident I can do comfortably with opens based upon my past experience. So that's the reason I kept it as a reserve. Suppose if that is there, then go ahead with the rota. Because only thing is rota in that case, because diffuse disease wells, RCS, CTO, LAD disease, if slow flow, no flow, that's the reason I secured the LCX pass so that you can maintain the flow. Even RCS slow flow takes place also, patient can tolerate. So that was the only one intention.
Thank you, Dr. Sridhar. And
so actually, Rajesh, can I make a comment?
Yeah, sure.
See, Sridhar, actually, I will tell you that when you do an angioplasty like this for the LMCA with the LAD and circ is involved, ideally you should prepare the lesion before just going ahead and putting a stent in any vessel at all. Actually, whether to circumflex or any LAD. So since you put an LAD circumflex stent, you just landed with an OPN balloon, as Rajesh told. If you had a problem, real problem by again the second OPN balloon also broken, then there is a dissection created, then your rota will be a problem. Anyway, you have an experience with OPN and you are 100% sure that even then there is a 1% chance that OPN balloon may not work out. In that case, a rota's chance will come down because of the mild protrusion of the circumflex stent. So in that case, I think the ideal way of understanding is actually in a calcified lesion, whatever you do, we should prepare the lesion before putting a stent to any vessel.
No, that is it. We have prepared and put the stand. So another
So
thing
you
is,
prepared the circumflex, but in
I will
LED,
do one. Just let me explain. Rota also, even if the open is if the annealing, if mild dissection, it's not a contraindication. Contraindication only ACS setup. If the dissection or thrombus is there, a contraindication. If the balloon slight dissection, it's not. We do many times. Even if the balloon is there not crossing, we can put the rota and do it. That is not a contraindication.
Sridhar, I have showed a case where I have used 3 and 3.5 balloon and then did a rota. But I am telling, if you do a rotablation distal to the calcified part, if you created a dissection, then is the problem comes. Otherwise, there is
Distal it will not come. No? We are only targeting the calcified segment. We are not going beyond. No? We are only targeting that area. That also guideline, everything is there. I think it's not a big issue.
I think Dr. Pratap's point is having a lot of calcification is the best to prepare the lesion before you put it.
Unless you dilate it, we are not supposed to put stent. So we have to prepare and put the stent. Even there also, if the stent projecting also, we can park in the proximal area and do the rota. That is not the big issue. And the lipid calcium also, I think the description is not proper. The lipid calcification, why 3 subsets are there. One is microcalcification, which suggests the acute inflammatory, that vulnerable block, where you have a plenty of bright spots. Second one is the spotty calcification, that is less than 90 degrees angle. That also indicates the vulnerable block. The another one is the calcium, which is the underlying with the overlying lipid, where you cannot distinguish between the lipid block and the calcium. That is the superficial. That these are 3 components of the lipid calcium. One is microcalcification suggests the vulnerable block, and there was spotty calcification suggests the vulnerable block. In addition to the thin cap fibroatherectomy, in addition to that macrophages, and in addition to the vasovarum, these are the features of vulnerable block features. Suppose if the lipid component is more, behind that, if the calcium is there, you will not see that clear-cut borders.
Correct.
Calcium.
My doubt actually, Sridhar, was basically when you see a severe calcium, I don't know, OPN, your experience may be telling, actually, I don't use OPN at all. I actually used only 2 cases where basically your experience is very big in OPN. So whatever the cases, when I see a lot of calcium, I just take a rota, and that is my practice, and that is what.
Actually, in our center, we do maximum rota diffusely calcified recently because we are doing registry for open NC. Okay. I showed one live case.
When you had OPN balloon had ruptured the first time, why did you persist to the second OPN balloon?
Because last time I showed one even apart live case I was operating diffusely calcified, and that open NC, the thickness of the calcium more than 1 mm, length is more than 20 mm, and the arc is 360 degrees. It produced multiple fractures and stent expanded very nicely. So based upon that experience only, okay, I'm comfortable. This can go ahead like that. Otherwise, I would have not used that one.
Yeah, Sridhar sir, excellent case. And before putting stent, do you do a imaging and document that you have produced adequate lumen size? You have
usually I do it. Compulsory I will do it. But actually, I do before assess the calcium is superficial, deep, or arc, the expansion index. And after that, like open NC, rotor, IVL, if you are doing, fractures are there or not. If fractures are not there, if thickness is more than that, definitely I will repeat the upsize the bar, or you can go with the bigger balloon or use the IVL, see that fractures are adequate. Otherwise, the stent will not expand.
So do you have any criteria to say that this is the time you should take a stent?
Yeah. Criteria, that means if the thickness is less than 0.5 mm, that the 0.5 mm thickness is there. If the that is most important. Fractures are there, cracks are there. If these are there, definitely no need to upsize the bar, no need to use the IVL. You can straight away go ahead with the stent. But if the thickness is more than 0.5 mm, fractures are not seen, definitely you have to upsize the bar or upsize the balloon. And unless you do that, it will not expand.
So anything to do with the lumen size before taking?
Lumen size also, frankly, they have not described the lumen size for the calcium, but these are the 2 important predictors of this stent expansion.
Yes, sir. So Pratap sir, you said.
I think Selumani, that is a very important question what you asked, the lumen size. Actually, lumen size of 4.5 millimeter in a vessel of 6 millimeter wide vessel with a 4.5 lumen, whether to do a rota or any intervention at all. That is a big question mark. Actually, that is until it is nobody answered that question. I
No,
think
but
it is
in my
4.5 is not
practice,
a critical lesion. It
what
doesn't
I
require.
do is, what I do is, we try to bring the lumen to at least 3.5 before you take a stent. Because
okay.
my experience, what I have seen is, if you prematurely take a stent, before producing a lumen of at least 3.5 with fractures in the calcium, as rightly Sridhar said, you will land up in under expansion. So once you land up in under expansion, if the calcium is not allowing, whatever you do, it is very difficult to expand the stent. So that is what I practice. So I just wanted your opinion also.
That's
And
a very
Pratap
valid
sir, for
point.
your point, you said rota is excellent for superficial calcium. If it is deep, for example, deep there for 3.5 balloon is not expanding. It is not yielding. It's producing a shoulder there or dog boning. So for such cases, what balloon do you use?
If a deep calcium, only two options. Because rota will not be helpful in such
Don't
cases.
help. Yeah.
Either use the IVL. IVL is very effective.
Or
for deep
OPN.
calcium, or OPN. These are OPN. Even we did for some rota cases where stent, even after rota, because upsized burr was not there, then we have put the stent. We were trying with NC, it's not expanding. That time we used open NC, it expanded well. Though we have documented OCT wise, there the thickness more than almost 1 mm and fractures were not seen. In the shelf, there was no additional rota upsized bar. Then what else we can do it? We have stented and we upsized with the open NC, then expanded. So such instances are there.
I have a question, Dr. Pratap Kumar. You showed very good cases. The second case, the RCA case which you showed 360-degree arc of calcium.
Yeah.
Won't an IVL, I mean, better than a rotablation, because in rotablation there'll be a wire bias and
Actually, Rajesh, everybody is talking about IVL. IVL is available for the last 6 months to 1 year. You know, Kerala, many people started using in 6 months to 1 year time. And many people, I think, over usage of IVL is there. That is what is my concept. And what Sridhar is telling and Selvamani is telling, we are getting IVL and OPN for the last 1 year or 1.5 years, not before that. See, people were doing all these cases much before also. I'm telling that when you have a gadget available, you can utilize these things. And I did not have
take a
that
scientific
one.
discussion.
Well, I understand. I did not have that one. Ideally, if you look into that, basically, an IVL definitely would have created an excellent result before that. I just did a rota, 1.75 1.5 or 1.75 rota, multiple balloon dilatation. I usually do a cutting balloon in all these cases. Earlier practice, I'm telling. Then an NC balloon to create a good lumen, then only I just go ahead with the stenting. That is my practice all the time. Now, when we have OPN as well as IVL is available, people should have a liberty of using it, but IVL is actually the cost will make a real problem for us.
But I think a rota is very cost effective. Even balloon uncrossable lesions and diffuse long lesions, single rota bar you can manage everything. As Dr. Pratap Kumar said, it's the most cost effective and more effective tool compared to any other device available in the market. So like IVL, if you diffuse
for calcium.
Yeah, for calcium, you have to use two balloons, like plasmally distal,
Sure.
more costly.
Sure. No, that is what Sridhar, I prefer to take a 1.5 or 1.75.
Yeah,
1.25 is taken only for the CTO calcium. Otherwise, I never take 1.25, 1.5 and 1.75. With 1.5, just go with a cutting balloon and I take a cutting balloon and then with the larger size NC balloon and finish it off. Now we have liberty of getting all these things. And if the patient is affordable and the system is allowing to do that.
Yeah. Yeah, I think.
Comments from the panelists?
I have a question actually. How do you ideally manage when you have a balloon uncrossable severe calcific module in ACS situations?
Balloon uncrossable, anyone wants to
tell? ACS.
Yeah, balloon uncrossable.
Severe ACS situation, especially in relation to the safety of a debulking agent.
Yeah, in ACS case, the ACS is because the one is block rupture, block aeration, 7 to 10% of the cases because the calcium nodule. So calcium nodule, this is like acute and chronic lesion. Most of the time, advanced stage where there's a lot of calcium and gradual overgrowth of calcium and with sudden closure or erosion calcium nodule leading to thrombus. In such cases, there is no contraindication to rota. We have advanced stage balloon uncrossable lesion. Most of the time, exchange with the wire. If the thrombus burden is not too much, then many times we can get away with the rota.
Nodule
First
is
do the imaging. You will see mainly it's because the calcium nodule with eruptive nodule, and in such cases it's recommended.
Farouk, actually, there is no absolute contraindication for in a STEMI or a NSTEMI situation with the thrombus. But I'm just telling you that in an uncrossable lesion, you can still use rota, but with precaution.
Yeah.
When it is thrombotic, is not when you have a severe thrombus in that situation.
I have used nearly 5 to 7 cases, but actually I'm just telling you all the cases went well without any problems. But I'm telling that this is actually telling is a relative contraindication for automation, mainly in the thrombotic milieu.
Okay. Yeah, but good evening, everybody. Like it was a great discussion by each one of you. And I welcome you all back to the main arena since it is time. And I'm very sure that each one of you would have had a great learning experience with various strategies in management of calcium. And all the cases were very interesting. And with this, I thank all the expert strategy presenters who did such a great job, and the moderators who took through this session excellently.